Hello, my name is Charles James. I'm the Executive Director of the Rural Advantage and Accountable Care Organization for rural health clinics, critical access hospitals, small rural hospitals, and anybody else who wants to join us. We're here today to re-record our February 23rd, 2023 annual wellness visit documentation requirements educational session. This presentation was developed in conjunction with Pinnacle Healthcare Consulting and Daniela Bolivar, who's now changed her last name to something I can't yet pronounce. But all of these slides are taken almost verbatim from material that Daniela and Pinnacle has provided to us. We've already talked about annual wellness visit billing. Welcome to Medicare visit billing. How do we get our rural health clinic visits to appropriately reflect annual wellness? And welcome to Medicare preventive services. This session is about what are the documentation requirements that must be completed in order to report one of these preventive services, and most importantly, that the documentation supports the service and that we're meeting our measures for Rural Advantage. So today's agenda, first we're going to start with our Rural Advantage proposed scorecard. It's actually no longer proposed, it is our scorecard. Because annual wellness visits, as you will see on the scorecard, play such an integral role in our performance with the Rural Advantage. After that, we're going to look at the documentation requirements. Then what happens when we perform other annual wellness, what happens when we provide other preventive services with our annual wellness visits? What can we report? Are there line items that we can report? Should we be reporting other preventive screenings such as obesity screening, alcohol abuse counseling, depression screening, tobacco cessation? When and how can we report these other line items in conjunction with our annual wellness visits? And as important, we're going to look at the common deficiencies that we have seen when we've come out and audited the documentation for our participants' annual wellness visits. At the end of our performance year, Medicare is going to come and ask the Rural Advantage, here are a list of patients. Go make sure that the documentation of these annual wellness visits matches the disease burden reported there. That's how we'll be measured on our performance. A lot of the other things that we're doing are to support that, but ultimately it's going to be a record review to make sure that our annual wellness visit documentation is sound. So it's incredibly important that if we're submitting claims for the annual wellness visit, we have documentation. We know we're going very, very basic. If it's not documented, it wasn't performed. And of course, these annual wellness visits, as I've already mentioned, play a very important role in our performance with the ACO. Here is our proposed scorecard. You can see that we place heavy emphasis on education and learning as we're doing here today. But our annual wellness visits, for which we're asking greater than 70% of our eligible patients receive their annual wellness visit, 40% of your Rural Advantage score will be based on annual wellness visit compliance, 40%. You can see a total of 30%. I have poor math skills, but I know 15 plus 15 is 30. 30% is a result of attendance at educational sessions, both live and virtual, as we're doing here today. So annual wellness visits are the most important thing we can be doing in order to achieve savings, 40% of our score, This is our Rural Advantage scorecard. This has been vetted by our quality committee. This has been approved by our board, and this has been distributed to participants, and we'll be reinforcing these measures as we go throughout our performance year. The annual wellness visit is a personalized prevention plan. Remember that. It's not just a visit, it's a personalized prevention plan. For beneficiaries, Medicare beneficiaries, who have exceeded their first 12 months of Part B coverage. So if they're within their first 12 months of Part B coverage, they're eligible for a Welcome to Medicare visit, but they're not eligible until that 13th month of coverage for an annual wellness visit. We talked about billing, so we're not going to linger on these a whole lot, but remember, our annual wellness visits are different from our Welcome to Medicare visit. The annual wellness visit is a standalone encounter, which means if it's the only service provided that day, we get paid an encounter. If the annual wellness visit or a standalone encounter is performed on the same day as another medical visit or another preventive service, it's not a separately payable encounter. We have a big problem in a rural health clinic world. We think that not separately payable means not separately billable, and those are two very different criteria. A standalone encounter is not separately payable, but we want to report every preventive visit and every standalone service with or without another encounter. Let's now take consideration of how we get paid for that off the table. We're talking about documentation. We have an annual wellness visit, standalone encounter. We encourage you to accurately report other line items with that claim. Remember, separately payable is different than separately reportable. Separately reportable is really required as part of your Medicare contract. Your Medicare participation agreement says you'll report all services as rendered. So where we're leaving services off because we think we can't bill that as a rural health clinic, we're wrong. So we need to change that thinking. As we know, if when we report an annual wellness visit, we cannot have coinsurance or deductible applied to that preventive service or annual wellness visit or Welcome to Medicare visit. The beneficiary coinsurance and deductible are waived for all preventive services. So if we're having a bundling process in our revenue cycle management operation, that bundling process, we need to be sure that we do not bundle preventive services so that they get a copay or deductible. But I keep saying we're not here to talk about billing, are we? We're here to talk about documentation. So let's proceed. The components of the annual wellness visit provide focus on long-term needs that may be missed during, dirty word, routine. We don't want to say routine. Long-term healthcare needs that may be missed during other clinical visits with their primary care or other specialty provider. So this is a chance for an extended conversation, not just about acute problems. Of course, many of our chronic diseases are causing multiple acute problems, and the point is to go beyond that and come up with, remember, that personalized prevention plan. Personalized prevention plan. Integral parts of the annual wellness visit, and they change every year a little bit because CMS comes up with different objectives. So first of all, very important, patient risk assessment. Number one deficiency of annual wellness visit documentation review is that we're missing the patient risk assessment. So that's the number one component. Other components are screening for fall risk, depression screening, tobacco screening, substance abuse. Substance abuse risk and opioid prescriptions are new measures that Medicare added to our annual wellness visit documentation requirements for program year 2023. So when Medicare comes back and asks us for documentation of our annual wellness visit, they want to see, yes, we've assessed fall risk, yes, depression, yes, yes, yes. Now here's what to keep in mind. We're talking about traditional Medicare. All of your other payers want, I'm going to use a term here, all of our other payers want us to close the gaps to prove that we're closing the gap, one, that the patient's ready for an annual wellness visit. We perform the annual wellness visit, we've closed that gap. It's a care gap we've closed, just getting the annual wellness visit. We've assessed the patient's fall risk. Patient is at risk for falling, and I don't know all the fall risk criteria, but we've assessed it, so we fire a CPT level 2 code for fall risk. We've closed that gap. We've assessed that our patient isn't at risk for depression screening. I don't want to use that example. Anyway, I'm going to move on from there because we're going to focus on depression screening later. When we assess fall risk, when we do depression screening, when we do tobacco screening, we're closing care gaps. When we do annual wellness visits, we're closing care gaps. So that's the language I sort of want to get to automated in our own minds. We're closing care gaps when we do these things. The point of all this is wellness education, so that the patient goes away with an understanding of how to treat their chronic conditions and a better understanding of those chronic conditions and education on how to prevent those chronic conditions becoming worse, how to address their current disease burden, education, personal prevention plan. It's a key component of what we're doing. And on the topic of should we report other line items with our annual wellness visit, Medicare wants us. We're encouraged to provide advanced care planning in addition and in conjunction with an annual wellness visit. We can provide advanced care planning as back to that standalone encounter. Advanced care planning is a standalone encounter. If we provide advanced care planning during an annual wellness visit, we will not receive any additional compensation, but we've closed the gap. Closing that gap is much more important to you than the line item. So we're actively encouraged. Part of the annual wellness visit is an advanced care plan conversation. And advanced care planning is end of life conversation. More on that momentarily. Annual wellness visits are intimidating. They appear to be a considerable amount of work on an already stressed, overburdened staff. Our nurses do most of the work. The doctors and providers, of course, come in and provide the diagnosis and the educational plan. But if a provider is the sole person, your nurse practitioner, physician, PA, if they're the only ones doing the annual wellness visit components, we're off track. Annual wellness visits are a team sport. It takes all of your care team to get the annual wellness visit done. And conversely, it is not fall solely on the provider. It cannot fall solely on the provider to get these done, because then you have an impossible task. Annual wellness visits are a team effort in your medical practice. And the point of the annual wellness visit is this is our start to getting off of the fee-for-service gerbil wheel. More clicks, more clicks, more clicks, more clicks. This is the start of how we get off of that train, to mix my metaphors. We can see first we need to decide what type of annual wellness visit we have. Is the patient's first 12 months of Part B coverage? Welcome to Medicare visit. is the patient's second year of Part B coverage. It's an annual wellness visit and they haven't had it. It's not 12 months and it's not an IPPE. Is it a subsequent annual wellness visit? Then the subsequent annual wellness visit is 12 months after the initial annual wellness visit. You see here, of course, I have a step 2 circled of our annual wellness visit workflow. Of course, the first part is to identify the patients eligible for the service. Step 2 is gather all of our clinical and utilization data on the patient, and either the provider or clinical support staff performs initial screenings and a risk assessment. Clinical support staff, not the provider. See that? Clinical support staff is helping us gather utilization data, performing initial screenings, hopefully reviewing the patient's health risk assessment that they have brought in and self-reported. You can see that in step 3, the provider comes in and reviews the risk assessment, suggests diagnoses that present risk, address positives with the patient, takes recommended follow-up action, i.e. we have a personalized preventive plan for that patient, is where we finish. What I want to emphasize is support team and patient involvement. We've got to involve the patient in this. Patient has to be involved in it. We know patient engagement is a huge challenge, but it's not, the patient will listen to the provider. Sorry, nurses, the patient's probably not going to listen to you. But when the provider says you need an annual wellness visit, the patient will generally listen. So, this is the workflow. The emphasis, patient-reported risk assessment, and that the care team helps. Patient-reported risk assessment. So, of course, it doesn't have to be patient-reported, but it sure helps with workflow if it is. And the patient, those of our high performers with annual wellness visits, the patient comes in with a worksheet or completes their health risk assessment on the portal. I know that's fancy talk and wishful thinking with a lot of our patient population who don't have access to internet or perhaps don't know how to use a patient portal, but options are good. So the risk assessment can be patient reported, can be the patient can sit there and the nurse can do the risk assessment. Boy, it sure saves a lot of time if that's already done when the patient comes in. These are the components of the risk assessment. Demographics, self-assessment, psychosocial risk, behavioral, daily living, and instrumental activities of daily living. These are our health risk assessment. We can come up with any variety of tools to get this done. This is an example of the AAFP's Medicare Annual Wellness Visit. It's a great article that's cited from this risk assessment. AAFP has also some really excellent material. We start talking about value-based and closing gaps. That's our push here, folks, not just Medicare. Think of doing this for all of your patients, and not specifically this. Each plan has a little different requirement, but think more broadly than Medicare, traditional Medicare. Especially think about your Medicare Advantage patients, especially. Here's a sample of the risk assessment. We've gone through the patient questions. I don't know how visible that is, but I think many of you have slides. If not, please request slides from me. I'll send them to you, excuse me. Risk assessment example, AAFP. Here are the components of the patient-completed risk assessment. Fall risk, depression, cognitive, functionality, vision, hearing. here are the documentation requirements as a whole. I've got a few pages here, and I have in red what we typically see missing. Administer a health risk assessment. Either patient reported or provider support team has come in to do that. We see a little difference on the initial annual wellness visit versus the subsequent annual wellness visit. There's a little different requirements. Subsequent annual wellness visit, same elements for the risk assessment. We have to do a risk assessment every year. It's very important that we do a risk assessment every year because part of this, we're reporting our disease burden to Medicare. So when we do this risk assessment, the patient has lost a foot to diabetes. Now, I don't know the clinical way to say that, but if we don't cite that in our risk assessment every year, next year, if we don't report the patient's lost their foot from diabetes, Medicare thinks the patient has regrown their foot. So we have to report these every year, and that's how Medicare, critical function of Medicare knowing how sick our patients are, come from our annual risk assessments, which must be updated every year. The patient gets perfectly healthy every year until we report the risk assessment, and then the patient's sick again. We of course know that's not how it works, but now Medicare knows how sick the patient is, and it's got to be done annually. The absence of a risk assessment and our list of current providers, this of course can also come from nursing staff, self-reported from the patient, establish a current list of providers. These are the numbers 1 and 2 things we see typically missing from annual wellness visit documentation. I'm not going to go through each and every one of these. You can read some of these on your own. Patient's medical and social history. We know that's fairly typical E&M material. We're going to take patients' vital signs and measurements, which includes height, weight, body mass index, waist circumference, etc. Now we know why meeting these measures, your dermatologist wanted to know what your BMI was. So we have to take these, we have to take vitals. We saw some of these in a previous slide: cognitive screening, depression screening, fall risk assessment, functional screening, hearing screening. Then we'll update those for the subsequent annual wellness visits. And an updated screening schedule for the patient. How often does the patient need to get their mammogram? How often does the patient need to have their PAP? How often does the patient need to have their depression risk screened? Update the screening schedule for that patient. It becomes part of their personal prevention plan. We have a list of risk factors for which we have educated the patient on. And we have appropriate health advice and referrals. That's our personalized prevention plan, again in red. So these are the requirements to complete the annual wellness visit, is that the patient has a screening schedule and an educational prevention plan. Here's how to treat your diabetes, and that's documented in the note. Your EHR should do a lot of this work for you. Did you know that your Medicare Advantage plans want this information from you? If you go into your UHC portal and you find a quality payment program, we can help you find that. You go in, say, no, patient's hyperthyroidism is no longer present. Patients had their screening risk. Patient, we've had their annual wellness visit for. Medicare Advantage plans will pay $100 to $400 to know that, outside of the line item reimbursement. WellCare will pay anywhere from $40 to $80 for each of your patients. They threshold this, that they have a mammogram on. So establish written screening schedules, making sure your patients get those screenings. There's money lying in wait right now. So if we start to get better at these, and you do, it's just like my skateboard. Do it a few times, bump a couple elbows, you'll learn how to ride that sucker. And these get easier as you go. Advanced care planning. I like to remind everyone that advanced care planning are the death panels that we were told about that came as part of the Affordable Care Act. So the reality of advanced care planning is that this is preparing the patient's end-of-life decisions and documenting those, because we know an enormous amount of cost to the Medicare program comes from the last month of a patient's life. We expend great efforts to keep a patient alive, or perhaps it is not according to their end-of-life plan. So it's important, fundamentally important for that patient. I just had a dear, dear friend of mine over the weekend, family friend, everything is an uncle to me. He was able to pass it home. What a blessing. So advanced care planning is so important to your patients and their families. Let's get the line item on there, get it reported, and from a mercenary objective, get credit for it. We need to review current opioid prescriptions, current measure, we have to have that documented, and we have to screen for potential substance abuse disorders. Those have both been added this year. Those are part of our documentation requirements. We can see some comparisons for telehealth versus in-office visits. I'm not going to go through each one of those either. But we can see we can do annual wellness visits via telehealth. Here's the fundamental importance for telehealth visits. You know, we have our G2025 code. If you want to go back and retrieve what service was actually rendered for that G2025 so that you know it was an annual wellness visit, you got to post a dummy CPT code. If you just have the G2025, the only way you're ever going to know what service was rendered for that G2025 is by auditing the record if you don't have a dummy CPT code that goes with it. If you post an annual wellness visit, the code can't go on the claim, but we have it in the system so we can go back and look. That's a big caveat with telehealth visits. Helps to get the detail on the claim, even though we can't report that to Medicare. It's got to be kind of a dummy code. Here's our advanced care planning. Medicare wants us to report this line item with our annual wellness visit. Actively encouraged to do this. Guess what? Those of you that are on RVUs, annual wellness visit has the exact same RVU as a 90214. Advanced care planning also has is just under 2 RVUs. Those of you that are not on RVU compensation, you probably don't care. But there's a massive RVU pickup for providers. Sorry, hospitals, you don't get paid the extra line item, but consider it deferred compensation. The meeting the measure, closing the gap is more valuable to you than the line item. That's the way to think about it. Should we report the CPT code or not? To report or not to report? Let's answer the question. Any astute observers might find that I'm playing a little trick there, to be or not to be. Let's answer the question. To report or not to report? Report. The answer is, if it's performed and it's documented and it's due in that patient record, report, report, report. When in doubt, report the line item. Hemoglobin A1Cs. We need to be reporting our CPT level 2 claims on our UBO4s. They have to be greater than 0. So the dollar amount has to be 0.01. It should not affect your claims. We want the line item on the claim. That's the way to close the gap without having to go to the portal. If your payer, not just Medicare, sees that you've checked those A1Cs, you're going to get credit and incentive money for that from payers other than Medicare. So let's reverse the tide. We used to say, oh, we're a rural health clinic, we can only report the encounter line item. No. You'll only be paid for the encounter line item, but now we see why these additional line items are much more valuable than whether or not we get a line item payment for them. They're going to come back in shared savings and incentives to you from all payers. Close the gap with CPT level 2 on your claims. On a 1500, I think they're just zero charges. On our UBs, we need to make them 1 cent and report. High blood pressure, breast cancer screening. WellCare's paying $40 to $80 for every one of the patients on your panel that gets their mammogram. Every patient, you didn't do the mammogram, your primary care, but you get $40 to $80 per. Same with United. Depression screening. We have a number of different issues with depression screening. You see this is a PHQ-2, which would not constitute a screening, but it's in the note, and basically screening is negative and there's no follow-up plan. That's the PHQ-2. You could report the G8510 for one. There's some other depression screening. So look at this. We have an enormous source of confusion on these screenings have been, when can I report a depression screening with an annual wellness visit and when not? Until this year, it had been 15 minutes. We've dropped the requirement for the time required for annual depression screening. We're going to talk about that in a second. Any of these CPT level 2 codes that you see here, don't be afraid to report them. Tobacco counseling. Both of those are standalone encounters. Oh, we don't have time for the tobacco counseling today, but if you come back tomorrow, then you do have another encounter. Now, like statin therapy, those G codes, those are not standalone encounters. We know what are standalone encounters from the qualifying visit list. So, performed, documented, the patients do report the CPT code. Transitional care management becomes enormously important for our reducing hospitalizations and getting credit for that. So encourage everyone do transitional care management. Just remember, transitional care management is a phone call and a visit. 99495 is phone call within 14 days of discharge and a visit. Excuse me, the visit's within 14 days of discharge. 99496 is phone call and a visit within 7 days of discharge. That is a standalone encounter, or when performed by themselves, obviously their own encounter, and what have we already established? Reporting the line item is more valuable than the claim reimbursement in shared savings. It's enormously more valuable. Depression screening. I already alluded to this. In our previous session, we put a lot of attention into PHQ-2 versus PHQ-9. Most of our participants said we don't ever do PHQ-2. It's just they do PHQ-9 or they're done with it. An enormous confusion is, first of all, the depression screening is part of the initial annual wellness visit. We cannot bill a depression screening during the initial annual wellness visit or welcome to Medicare visit for that matter. We may report with a subsequent annual wellness visit. And the time requirement is now 5 to 15 minutes, which has been lowered from 15 minutes. It's in the Federal Register that the G0442, which is alcohol screening, and G0444, which is depression screening, have been lowered from 15 minutes And now the time requirement is 5 to 15 minutes. And yes, for all of the screenings where there's a time involved, we're expected to spend 100% of the time involved unless it's otherwise indicated. This is where I punt. We start talking to coders. This is the extent of my documentation knowledge, but we wanted to keep it boiled down for you today. This depression screening was one of the bigger questions relative to that. Most common documentation problems that we see are no health risk assessment, got an invalid annual wellness visit. No current provider list, got an invalid annual wellness visit. We would not meet those measures when Medicare audits us at the end of the performance year. No personalized prevention plan, no education, we have an invalid annual wellness visit. Don't make those mistakes. As I've been mentioning, this is not just for traditional Medicare, this is for everybody. Some of our plans have, of course, we wouldn't report a G0438 to WellCare. We can close these gaps with WellCare. Medicaid MCO plans, they're looking for the same thing. As we go through this next year, all of these other payers are what we're focusing on, in addition to just traditional Medicare. But this goes for everybody, what we're learning about here. How we'll report on the claims are a little different for each payer, but start getting those CPT level 2 codes out, because all of our payers will record the healthcare gap as being closed via claim information. The CPT level 2 codes will close your healthcare gaps. So I'm saying, change your thinking. Go from we can't report anything else to we need to report everything we're doing. Talk to us if you have claim problems. We had an extended opportunity for questions and comments last time. The last time we really focused on that depression screening and when those time requirements take hold. The time requirements are 100%. Opinions vary on that. Ask your coder. Ask us. We'll get to the coders. Depression screening, alcohol screening. Now 5 minutes. We have an event we're putting on, much like our Navigator that we had here in the fall. May 10th through 11th, InquaSeek will be with us. Compliance team will be with us. I'll be there. We'll be talking about Rural Health Clinic update, much more to do with rural health clinics this time around, but I will be talking about those quality dollars that are available now. So come join us in Springfield if you can. This is not a Rural Advantage required event. This is for your edification and for those of us that can't make it to some of the other places like NRHC in San Antonio. This will be a good opportunity to come get caught up. Here's how to contact me. I'm about to post this on YouTube. Hopefully I see you there. Thanks for your time.